At the annual American Society of Hematology meeting in San Francisco, we spoke with Dr. Monica Bessler, professor in the Department of Hematology Division and the Department of Molecular Biology and Pharmacology at Washington University School of Medicine.
You should see your family physician. You should see it probably the same day or latest the day after. And you would have to tell him your symptoms, and he will likely ask for how long you will have these symptoms and whether other symptoms are associated with it, like abdominal pain or headache or difficulties with swallowing, and whether you have noticed the urine to be dark every morning or whether it clears up during the day, and whether you have any fever with it. PNH, the full name is called Paroxysmal Nocturnal Hemoglobinuria, and this means that once in a while you have dark urine, and that occurs especially during the night, but you of course will see it in the morning, the following morning. And this is due to that the red blood cells are very sensitive to complement, which is a primitive immune system, and that lyses the red cell, and the red cell literally pop open and they lose the red color, and that's secreted by the kidney, and that's what you see in your urine. The underlying condition is often that the bone marrow doesn't work properly. And I always say to my patients, it's sort of the good news and the bad news. The good news is that in the environment of the bone marrow, there is a cell clone who can live and can grow. Unfortunately, it is not the right cell clone. It's not leukemia, which is important to know, but it's not healthy cells. The cell pop easily, and that causes the symptom and it can cause certain complication. It's certainly a possibility to live with it, but one has to sort of not to shy away and to work together with the physician how to have the best treatment options and possibility to live a normal life. First, your doctor will make a physical examination. He will see whether you are pale. He will see whether you have any site of infection, any site of bleedings. He will also see, look at your belly, whether you have a big spleen or a big liver. And he will ask you about your symptoms, and he will ask you about your family history, if anybody else had something like that before. And then he will order a urine test and a blood test as a start. So if the diagnosis has shown, or with the examination has shown that there is in fact hemoglobin in the urine, there is the second line of blood exams that should be undertaken, which includes the checking of the liver function and the kidney function, the extent of what we call hemolysis, which means how much these red blood cells are popping. And there should also be done a bone marrow examination to rule out any additional complications, such as myelodysplasia, which is sort of an early form of leukemia, which sometimes can be associated. The bone marrow will also show how the bone marrow is functioning at this point in time. Now, there is a very specific test which is needed for confirming the diagnosis, which is a blood test, and this is called a PNH marker test, which checks the white blood cells for the absence of protein, which are so-called GPI-anchored proteins. And this is a flow cytometric test which is performed and is very sensitive and specific, and will tell exactly the extent these abnormal PNH cells contribute to the hematopoiesis. First of all, he will have to determine, is it really blood in your urine? Because there could be many other causes that causes a dark urine. There are medication that causes a dark urine. There are certain vegetables, for instance, beet, that causes a sort of red-colored urine in certain patients. And it could also be that it is not hemoglobin, it's not the red color of the red cell, but it's really red cell itself. And then that would be a different cause. So he will have to examine the urine first and determine, is it red cells or is it the color of the red cells, the hemoglobin itself. PNH is commonly treated. There are three options to treat patients with PNH. One option is supportive therapy, as we call it. That would include red cell transfusion if necessary. It would include folic acid supplementation. It would include iron therapy if you would be iron deficient, and the treatment of infection when they would occur. The other possibility of treatment is the most aggressive treatment would be bone marrow transplant, which one would have to see whether there's a sibling donor available or whether that would have been an unrelated donor. And then there's a more recent treatment which is used when the hemoglobinuria is very strong and very frequent, and that would sort of block the activation of the complement and the popping of the red cell, and this is an antibody treatment with eculizumab. That depends very much on the treatment plan. So first, it would be very important for the patient to probably see somebody who is familiar with the disease, and their additional examination would have to be done to rule out associated complications or associated illnesses which would have to be treated at the same time as the PNH would be treated. And then one would have to establish a treatment plan and decide which direction the treatment is best. This can change. The presentation of PNH can change during the course of the disease. And most of the time, a specialist can work together with the local physician or hematologist. But it's important to have an idea what the long-term plans are. And the complications are associated according to the choice of treatment. Supportive therapy has relatively small treatment complication. However, if the disease is not treated aggressively, it is associated with complication of the disease, which is thrombosis or renal failure, or it can progress to aplastic anemia. The treatment with the complement inhibitor is associated with relatively small risk. The major risk is a risk of infection, especially meningococci infection, and you would have to be vaccinated for it, and you would have to know and carry a card with you which says that you have an increased risk of meningococci infection, and whenever you would present with fever, you would have to see your physician, and he would have to examine you and initiate antibiotic therapy. PNH is not inherited. PNH is an acquired disease. Your children will not inherit the disease. The only possibility is that PNH always occurs with bone marrow failure. The bone marrow failure condition can be inherited, but PNH itself not. What you would have to know is if you want to become pregnant, if you are a woman and want to become pregnant, you have to discuss that with your hematologist, and this is a high risk pregnancy with a lot of complications for yourself, the mother, and for the fetus. So if I would have cola-colored urine and would be diagnosed with PNH, I would like to make certain that the diagnosis is correct. I would like to make certain to what extent I do have PNH. There are sort of small PNH clones or large PNH clones, and the treatment of those would be different. I would expect to be able to discuss a treatment plan with my physician and know the different options of the treatment. I would have to know whether this is a chronic condition and how I would have to adopt my lifestyle and what my future would look like for myself and my family.